Today's case, we are talking about two burr hole technique in pineal gland biopsy, and this case is a middle-aged man with a large pineal tumor with unsteady gait and headache. You see here the first burr hole that we did ETV by that. We placed this first burr hole in front of the cochlear point, in front of the coronal suture, 2 centimeters of the midline. Very gently, the tuberous cinerum or perimammillary space open. You see the stoma of the pituitary infundibule anterior to the orifice. Very good flow happened because of obstructive nature of the lesion. And by Fogarty inflation, we got secured the stoma, and we also achieved acceptable hemostasis. After this burr hole, we placed the other burr hole in front of it, 2 centimeters in front of the first burr hole. Therefore, the second burr hole is literally about 4 centimeters anterior to cochlear point to the coronal suture. This anteriorly placed burr hole give us the opportunity to have a slant posterior angle to see the posterior region of the third ventricle, that is the habenula commissure, pineal recess, and the posterior commissure is placed and usually involved by this kind of the tumor. This is the final stage of the inflation of the Fogarty balloon, and you see the fine vasculature of the basilar tip here. Propontine space is spacious in this kind of the patient symptomatology, and good flow is granted here to have a good outcome. Now the technique is to have the second burr hole, and now we do a septostomy here. Why we do a septostomy? Because in all ventricular procedure, we usually do a septostomy. Set aside the Monroe is widely open, and the technique of placing the second burr hole is you should not let the fluid comes out from the first burr hole to have a very wide space of a ventricle to simply penetrate into it. Under direct observation by the endoscope in the first burr hole, we enter a ventricular cannula, and by seeing this ventricular cannula, we are confident that we are in the same and okay places to put the endoscope sheet again there. You see the good flow of the fluid through the second burr hole. At this moment, we take out the endoscope sheet and occlude it by the first foramina by patting a cotton patty over it to occlude the fluid, and we enter the ventricle through the anterior burr hole. This is what we see, and this is the very good view of the tumor. This is not the view that you can have with the single burr hole, and because of this, we are strongly advocative of doing the biopsy in the pineal region by putting 2 burr hole. This is the posterior surface of the tumor. This is the choroid plexus of posterior Monroe, and at this moment, this tumor looks like a glial tumor, a pineocyte tumor, or something like that. Sometimes the tumor are very bloody, and you should use a liquid hindrance over the aperture of endoscope, not to let the fluid comes out. At this moment, we do a coagulation over the surface of the tumor, and after coagulation, we use a tumor biopsy forceps to remove at least 6 pieces to let the pathologist that can do a good diagnosis. This is the moment that we take the tumor, and you should be very careful not let the blood fill the ventricle and occluded your view. Therefore, you should be very careful not touch the vessels, and if you see a vessel, avoid pulling it out carelessly, and coagulate it before entering the tumor is important. But so much coagulation also will disturb the pathologic report, and you should avoid too much coagulation. At this point, one hint in the surgery is that not putting pressure by endoscope over the posterior border of the monro, because you will injure the internal cerebral vein and thalamus striate. At the end of the surgery, we use only gel foam to fill the burr holes and not putting the bone there. And by closing very good the gallia, we should have a very good cosmetic also configuration at the end of the surgery. This is end of the surgery, and the patient will send to the ICU for close monitoring. And also, this is a very good view of the opened aqueducts of the sylvius after some partial tumor removal. You see that this obstructed aqueduct cannot be seen before.